Okay. Assalamu alaikum wa rahmatullahi wa barakatuh to all the viewers. Greetings to everyone here today. And first and foremost, I wanted to say, the Prophet said, "La yashkurullah man la yashkurun nas." Those who don't thank Allah, they don't thank the people. So first and foremost, I want to thank Dr. Donnelly and Dr. Ben Gray for being here with us today. And as most of you know, that in New Zealand, we are about to have to vote for a referendum about the end of life care. And I think this is a platform that we'll be discussing about the issues on this referendum, and from two different perspectives, Dr. Donnelly as a palliative care consultant and Dr. Ben Gray as a general practitioner. So first and foremost, can I get Dr. Donnelly to tell us, to the viewers, a bit about yourself?
My name is Sinead Donnelly. I'm originally from Ireland and I've been in New Zealand for about 10 years. I'm a palliative medicine specialist and I also practice general medicine in a hospital.
Okay, and Dr. Ben Gray, a little bit about yourself?
So I'm a general practitioner. I have been working mostly in Newtown in Wellington at Newtown Union Health Services, which is a high needs practice caring for sort of multi-ethnic community. And I work half-time at the university as a lecturer in general practice and convene the course for the medical students in professional development and ethics.
Yes, and I'm one of the students that Dr. Ben Gray taught. So, okay, now let's start. So Dr. Donnelly, just if you could explain a little bit about palliative care, what actually it means, and how does it been practiced in New Zealand?
Well, palliative, the word actually has a lovely origin. It was coined by a Canadian surgeon, Dr. Balfour Mount, and it's come from pallium, meaning a cloak or a shield. So the idea is that you're cloaking or shielding someone in care, realizing that you can't take away the underlying illness, but that you're surrounding them or wrapping them around in care. So that's the word palliative really explains its philosophy and its aspiration. As a palliative care doctor, a palliative medicine doctor, I started in Ireland, my training, then went to Glasgow and then the United States, and now I work in Aotearoa, New Zealand. Palliative care can be practiced in different ways in different countries, different systems of setting it up. So as a doctor working in the hospital, palliative care, they'll have a palliative care team in the hospital, and that will be a consultation service where other doctors, like an oncologist, a cancer doctor, will ask the palliative care doctor or nurse to come in and give some advice and support the patient and their family. So the doctors within the hospital, the palliative care team, the nurses, they try and relieve people's symptoms. And these are people with advanced illness. So an advanced illness isn't just cancer. It used to be associated, like hospice care, palliative care was just for people who had cancer. But now it's for people with any advanced progressive illness. So that could be heart failure, kidney failure, liver failure, COPD, emphysema, motor neuron disease, all the neurological conditions, as well as cancer. So that's within the hospital sector. Generally, it's a consultation service. The palliative care team supports the other doctors and nurses and the teams in the hospital to look after patients who have advanced illnesses and who are facing their death in the near future, but not in a certain future. And then in the community, you associate it, certainly in New Zealand, with the word hospice. So that's the services if someone is going to die at home, supported by their family or friends. You'll have a community palliative care service. And generally that would be nurses and doctors and a palliative care team like physio, occupational therapist, social worker, spirits chaplain, even an art therapist, music therapist. They potentially would visit you at home and support you together with, as Ben will say, with the primary care team, which is central and core to the care that people receive at home. So just to acknowledge Ben, and in general practice, if someone is to be cared for outside the hospital setting under palliative care, the GP and the community services are fundamental and core and central. And the palliative care services just support the primary care services in caring for someone who wishes to die at home. And in New Zealand also, an awful lot of people die within aged residential care. So that's in a rest home, at hospital level care, or rest home level care, or even dementia level care. And again, the primary care team would be somewhat involved, and then the palliative care team would also support the GP and the nurses within that rest home or hospital level care, residential care. So that's a summary of the structure.
Thank you. I think that's very well said. So I think let's go to the straight to the point. But I'll start with Dr. Ben Gray. If you just explain to us, I think we had a discussion earlier about a lot of people still misunderstood this end of life referendum, and they assume that this is similar to what either switching off the life support or removing away the treatment, and they think that's what the referendum is all about. Would you mind just go through that a little bit about the end of life referendum as you understood it?
Sure. So I think it's important to be very clear that the referendum is about a particular act of Parliament. It's not a sort of a question about whether you agree with euthanasia or not. It's about whether we want this act to be enacted. So the things that are in the Act are saying that if you are thought to have less than 6 months to live, and Sinead, please butt in if I get any of the detail wrong, and you have unbearable suffering, then you can apply to have assistance in dying, and there's a structure to enable that to happen. So this is quite different from what currently happens. So what currently happens is that people are cared for until they die. In palliation, the focus is very much on the needs of the patient and keeping them comfortable. And there are times when some of the medications that we might use, and there's a well-described doctrine of double effect, which I'm not even sure it has a big influence, but the idea being that sometimes you might give some medications that might hasten death, but actually they're being used to control symptoms, and the goal and the aim is controlling symptoms. So the current regime is that as a doctor, I am unable, if someone asks me and says, look, I would like to end my life now, the suffering is unbearable, you have been unable to control my suffering, I would like you to kill me now, that's currently illegal, it's against the law. This act would enable it to be within the law for a very sort of narrow group of people. Okay.
Would you like to add anything more, Dr. Donnelly?
Oh, I have a lot to say. So I just start a tiny bit. In reading the End of Life Choice Act, which is exactly what Ben has said, it's not whether you want euthanasia or not, it's about whether this act, which is already kind of legal, we're just bringing it into force. It cannot be changed. Once the people, more than 50% of people vote for it, as it is now, is exactly how it will be. And I see an awful lot of risks in the way that it's written. And also from a legal point of view, a lot of lawyers see a lot of risks in the way it is written. It was a private member's bill rather than a government bill. So it didn't go through the normal system of checks and balances and through a particular parliamentary process. And as a result, a lot of lawyers in New Zealand think that it's a dangerous bill. Now, clearly I have a very strong view about this. So, and I could go through every point on it, but I'm not sure how much that is appropriate. But I'll just say, I would suggest when Ben was saying that it's a narrow group of people that would be involved, I'm not so sure. If you take the total number of people who die in New Zealand and then take the number who die each year that could receive palliative care, in other words, their death is somewhat foreseen, that's about 25,000 people. So there are people who have, an advanced progressive illness that would fit potentially with this legislation. That's a large number of people to come within the potential scope of this. It's not just for people with cancer, it's for people who have a terminal illness, which is interesting because terminal isn't a word that I use in palliative care at all. It's not a scientific term. It doesn't define where the person is clinically as far as I'm concerned. So in addition, prognosis and doctors who are listening and nurses who are listening on this will realize that very often we get the prognosis wrong. So, and why did they decide on 6 months? That's what they say, that you have to have a prognosis of 6 months. And the literature, even out from our own experience and also from international literature, we mostly get that wrong. Prognosis is an estimate. It's not as if we plug everything into a computer, your demographic details and your clinical details, and out pops your date of death. And then we could just go backwards 6 months and say your prognosis is 6 months. That's not what happens. It's an estimate. So you've got phrases like prognosis, terminal illness. Then there's an advanced state of irreversible decline, I think, in capability. Well, that sounds like a definition, but it isn't. If you're 85 and you've got a certain amount of heart failure, that's an advanced state of irreversible decline in capability. Even if you're 95 and have no other illness, it's an advanced state probably of irreversible. So again, what I'm suggesting is that the phrases that are used in this act are loose. They're not actually, they don't define. So therefore, the scope is much greater than a narrow scope. I think that a large number of people will have to think, if this is legislated for, should I ask for this? Am I a burden to my family? I can see the pain in my daughter's eyes when she has to come and visit me. I feel lonely at home. I don't want to go to a rest home. I've got heart failure. I am not 88. I've got a bit of kidney failure. I fit the description. I could die within 6 months, and I should ask for it. And that's my greatest sadness and concern, that we're actually adding to the burden, the human burden of life, if that makes sense to people who are listening.
Yep. No, that's good. Dr. Ben Gray, before we continue, I just wanted to introduce to Dr. Donnelly and Dr. Ben Gray. This is Brother Mama Thompson. So he's part of Voice of Islam with myself.
Salam to all. Sorry, I was late. I had trouble getting on.
Yes. Well, Dr. Ben Gray, do you want to add anything about what Dr. Donnelly have said just now?
Oh, no, I think the points she's making are all absolutely fine. I think that one of the issues in terms of, it might be useful to understand why is there a debate, and I think that there are a number of contributors to this. In my view, one of the strongest contributors is that we don't fund palliative care adequately.
Yep.
And there are many people who have had experience of relatives and friends for whom their death seemed to involve more suffering than they would like for themselves, maybe is the way to put it. And I think that's an important thing for us to remember. And there are a couple of elements to that. One element is, and this was certainly the case in my own family, a fear of dementia. And there are many people I've talked to in discussing the euthanasia bill where they've said, well, look, I wouldn't like to die like that. If I became like that, I wouldn't want to live. And we need to make clear that if that was the motivation of anyone who's thinking of voting for the referendum, that in fact they're not covered by this bill. Because you're only able to apply for this if you have capacity to make that decision. Anyway, so I think one of the big drivers is really about the adequacy with which we currently provide services. And I think the numbers, correct me if I'm wrong, Sinead, is only about 30% of the population who benefit from hospice or palliative care services as they die. So the large majority of our population don't have access to those services. It doesn't mean that they're necessarily having an unsatisfactory experience of dying. Many of them will be being cared for by their GPs, and a significant number will be dying suddenly without a need particularly for sort of end-of-life care in that sort of way. So I don't see it, but the fact that we rely on cake stalls and raffles and the like to fund palliative care, I think is something which, if we're concerned about suffering at the end of life, I think that putting more resources into that is a far less controversial and more certain way of improving end-of-life experiences for a larger proportion of the population.
All right. Can I ask a question, Dr. Donnelly? Because you've been working in many different countries in palliative care. How do you find New Zealand? In terms of the fundings and the service in New Zealand, palliative care compared to the countries that you've worked with?
Well, I have to respect where I'm living at the moment and my colleagues.
And where you're working, I assume as well.
Yeah, that's right. I think that to take Ben's point is the most important one. During the COVID pandemic, I overheard people within the hospice world talking about reassuring their staff, well, at the moment, you don't have to worry about your salaries. And they were referring to the fact that the hospice shops were closed during the lockdown 3 and 4. And then I just thought to myself, that's a reflection of how this society really, prioritizes care for our most vulnerable people who are dying. What other part of the healthcare system depends, as Ben was saying, on 50% on average funding from charity and donations. Of course, there's an advantage to having community support and the community all involved in fundraising, but that should maybe be for 5% of the total funding.
Yes.
The extra luxuries of an art therapist or a music therapist. So it's very clear that New Zealand, despite the goodwill, certainly of the workers, the people involved, but that at some high level, it's not, the care of people who are dying is not valued, is not prioritized. And in my view, I suppose because this is the area I work in, I feel those people are one of the most vulnerable group of people in our society.
Okay. Right. I did listen to one of your interview that you did on the TV, and I think you mentioned about there are many points that you can either criticize or you can question on the bill. Do you just want to? I think the one that struck me as of serious point was a coercion that you mentioned, which is the elderly population can get coerced to actually take this or to go ahead with this, despite they are not willing to. And I think I was reading the article from the NZMA, and they did a study in Holland. I think there was a mention about over 1,000 people, 1,000 elderly population may actually they do it against their choice because they feel like they've been coerced to it. I think that's the way how I understood the article. I mean, would you able to elaborate on that point?
Well, just from my experience, and Ben can speak from his experience, and within the hospital system, older people in particular, it would be the elderly, they often come in under general medicine in the hospital and they say, I am a burden, don't do much for me. So someone who's in heart failure, got pneumonia, and there's social issues, and they have said that. So in this environment where people are already feeling a burden by the society that we've created, I think this is very dangerous to add in then this legislation where a doctor is kind of state sanctioned to end someone's life. So, and as unfortunately New Zealand has a high rate of elder abuse, that's already clearly documented. And unfortunately, often that comes within families. It's psychological or physical or financial. So if you put all these things into the mixture, then adding this, what I would consider the lethal and final dose of legislating for euthanasia puts, I feel, people at great risk and our most vulnerable people. So I suppose that's as much as I'd say about being a burden, and that's related to coercion. So, for example, if you're, again, I'm just picking this age, 87-year-old person with heart failure, and you're living on your own, as I've said, and you can see the pressure on your daughter or your son who has to come and visit you, and they're trying to do all their other jobs, and maybe they're going through a divorce or something. There's all other issues, and you see the pressure that your family's under. Even that, you internalize that, and out of a sense of duty, if this is legalized, you may well ask for it, and that distresses me greatly.
I see there's a question there asking me whether the bill can be problematic for doctors working in low-cost practices in terms of health literacy and so on, and language barriers. I think my view is that that's probably not that likely, in the sense that if there's low health literacy and language barriers, they may not know of the existence of the bill or the detail of how to go about it. So I think experience certainly, and I was writing a little bit about the Oregon experience, that the demand in Oregon has been much more amongst those with high levels of education and within the majority white population. And of course, Oregon's not the same as New Zealand, and it's just one example to compare with. But I think that that's likely to happen to some extent. But I think in many ways, the issues are really tied into the question of whether we do an adequate job of caring for people from these groups where language might be a barrier, for example, because clearly you can't do the sort of assessment required of this act if you haven't got access to interpreter services. And so I think it's the sort of thing which, yes, there are some risks in terms of if we aren't doing other bits of our job very well because we're not using adequate communication and adequate interpreters, then yes, there are some risks with this piece of work as well in the same way.
Okay. Dr. Donnelly, do you want to continue with your points on the issues that you've got with the bill as much as you wanted to go through?
I mean, one lawyer has described it that it's, as it's written, that it's kind of a conveyor belt of essentially administrative steps, that once a person requests it, the process begins. It doesn't, for example, if a patient requests it, it doesn't require that a specialist doctor, for example, in the illness that person has, assesses the person. So it can be any doctor that patient sees. That doctor doesn't have to know the patient. The patient doesn't have to be known to that doctor. And the second doctor who signs off on it is from the Ministry of Health, what's called the SCENS group, which I understand will be doctors who are in favour of euthanasia. So they're the people who will be signing you off. So it's when I read it, it lacks all the aspects of care and thought that I practice in my profession as a doctor. It doesn't say that we need to investigate what's behind the patient's request, which is what we do every day in palliative care. For example, people who are facing their death, they can say, and they do say, I wish it was all over, this is too hard. And in response to that, in the world of palliative care, we see that as an opening, to delve deeper and to explore what's behind that suffering. None of that is allowed for within this act as it's written. In addition, in other countries where they have, for example, a similar bill in Canada, and then in Victoria, in Australia, and in Oregon, as Ben has mentioned, there's a cooling down or a cooling off period, in which case like 20 days or 15 days or 9 days. In New Zealand, there isn't any. And the Ministry of Health advised Parliament that in fact it could happen within 4 days. So, and we all know as doctors and nurses how people change their minds, So there's nothing to protect the patient to give them time to change their mind. The assessment of capacity, the referral to a psychiatrist is not if you as a doctor think the person is depressed or has mental instability. The only reason to refer to a psychiatrist is to confirm the capacity, that the person has the capacity to understand that if you inject phenobarbital and propofol, that they will die. So the referral to the psychiatrist, which is documented in this act, is not out of caring and trying to put you back from the decision. It's to just to determine your capacity.
Just to tick a box.
That's how I perceive it. That's how I perceive it. Yes.
Yeah.
So they're just also to say the New Zealand Act, which is binding and which cannot be changed. It's for euthanasia and assisted suicide. So euthanasia is where the doctor will sit beside the patient and either set it up so that the patient can inject themselves, or the doctor injects the medication and they die within seconds, or they put a nasogastric tube down and they pour the medicine in and the person dies. That's euthanasia. The doctor is the agent. The assisted suicide is where the doctor writes a prescription and the patient goes to the pharmacist who gives them this medication to take in their own time. So unlike Oregon, which is just assisted suicide, and Victoria in Australia is just assisted suicide with, except for one slight caveat, the New Zealand Act is for both, which is similar to Canada. And it's interesting that in Canada, more than 90%, if not, I think 95% of people are requesting euthanasia. They want the doctor there beside them rather than assisted suicide. So I suppose I view that including the doctor in this as being this agent to end someone's life is kind of putting a cloak of legitimacy over the whole thing. And I think somewhat to me that proves it a little bit, that most people want the doctor there. They don't choose assisted suicide if euthanasia, with the doctor providing it or injecting them, is an option.
Yeah. Maybe I could respond to the other chat that's in there that's asking about what the doctor's burden in engaging with this might be. And I've got a slightly different view from Dr. Donnelly. There's probably been 2 or 3 times during my career when, if assisted suicide or euthanasia had been available, then I might have considered it. I don't need to go into detail, but it's not something that I'm fundamentally ethically opposed in all circumstances. But one of the things that I feel about my job as a GP is that there's a considerable burden that we carry for our community in listening to their grief, in helping them through their hard times. And that one of the things I feel about this act is that it's asking us to take on more of a burden than we already carry, and it's not something I'm particularly wanting to do. Although, as I say, it's not. I mean, I actually had a recent experience of a patient for whom she was in the last phase of her life, and we had the conversation about euthanasia, which of course ended with me saying that it was illegal. But had the law passed, I would have talked some more with her about it. I'd known her for 20 years, and in that setting, I could have seen it as part of my caring for her. And, you know, the burden wouldn't have been too great. But I think the question of doing this for a number of people, particularly people you don't know, I think is, as Sinead has pointed out, I think it's highly problematic, because all of those questions of prognosis, which if you haven't known the patient during their illness, your ability to judge prognosis is significantly impaired, even if any of us were any good at it. And I think particularly the issues around coercion. And one of the things that I think about this is that if we're talking about relieving suffering, someone choosing to end their life may well create suffering for others, particularly the other family members. And we've had experience within our congregation of a person who ended their own life, and we could all see the suffering of her daughter, who was very distressed about the way in which things had gone. So I think the problem, as Sinead illustrates, of having doctors who don't know the patient being the people who are administering this act, I think is problematic. And yes, I wonder about how they will carry that burden. And I think it's a difficult area, which I feel that the legislation has gone ahead with a sort of, I'm sure there'll be someone who won't mind doing this approach.
Of course, yeah.
Rather than a more, thought through process. I mean, and there may be people who are prepared to do it within a particular constraint, and I am not fundamentally opposed to that. I'm opposed to this particular act because I think the way that it is set up is as Sinead's described, not acceptable. The other point that is really an extension of the concept of the discussion around the funding of palliative care is that the bureaucracy needed to put in place to run this regime is quite substantial, and that any doctor that's involved in providing euthanasia for a patient will involve a lot of time and therefore probably a lot of cost to the patient. And so in terms of it being available, it looks to me like if this does pass, then it'll be something that will be available for those who are well off enough to pay for it, but not available to necessarily all of the population who might like it. So it increases inequalities. It means that those who already get a lot out of the health system may get a little bit more of what they want out of the health system at the expense of those who don't get as much out of the health system.
So is that with that sort of thing, does that mean that those who are in a lower socio-ecological area are going to have less opportunity for this? And a lot of those may be people who are probably opposed to it anyway, from certain backgrounds, nationalities and religious backgrounds are probably opposed to it anyway.
Yep.
So that means that their taxes are going to be funding other people again. And then, like you said, if there's that cost to go into that, it could have gone into palliative care, more into palliative care to fund that, to help the people go through that system. And if, like you said, you're not opposed to it totally, but if you have the right circumstances, rather than now people can just tick a few boxes and they get what they want and just
I mean, I think one of the issues in here for me is that in order to set up that regime, it has already taken a large amount of time and energy from a lot of people in the sector to have the debate. If the referendum passes this act into law, there will be a lot of time needing to be spent setting up systems to respond, which is, and it's not just the money, it's the doctor's hours and the nurse's hours and the DHB's hours, and every organisation will have to have systems in place to respond to what the Act requires, and that's a whole lot of effort that isn't being put into sorting out problems with COVID-19, rearranging our health system and doing a better job of detecting and treating cancers before they reach this phase. So it just feels like a whole load of effort and trial for what I don't think is a particularly worthwhile area to do it. I'd rather put all of that energy into another place.
Just to say, in relation to kind of inequity, I think what we were referring to, I would see it more that the wording of the Act is that you have reached unbearable suffering or you have an advanced illness. We just think of who are those who reach that level of advanced illness the fastest. In other words, who die sooner? Who are the groups who die earlier? So in fact, for example, we know the inequity for Maori or Pacifica. So they reached a level because of their renal failure, heart failure, diabetes, all the issues, and they're not accessing healthcare. They'll actually reach the platform that would enable them to be considered for youth earlier than others. Does that make sense?
Yes.
Because they die earlier. That means they reach the advanced stage of their illness earlier. So therefore, they potentially, it's going to exacerbate that inequity. So that's seeing it from a slightly different angle. Just in relation to the impact on the doctor, moral distress, there was a palliative medicine doctor recently from Victoria, which is the state in Australia which legalised assisted suicide recently. She used the word devastating, that has had a devastating effect on the palliative care team and on the palliative care sector. So that's just an interesting insight. And in relation to Canada, as you know, in this Act, not only can a doctor provide the euthanasia, be the agent, but also the nurse practitioner. So that would be the potential for New Zealand. Well, in Canada, it's similar. And the nurse practitioner who is paid to provide palliative care now provides euthanasia as well. So the funding that went to the nurse practitioner to provide palliative care is now divided between euthanasia and palliative care. So that's just another example, as in what Ben is implying, the complexity. Of course, I could never intentionally end someone's life. That's just outside my. So that's where I suppose. Yeah, I would never. That would never reach that place. And there are a lot of doctors who would have a similar view. But in fact, what we're voting on October the 17th, which is as Ben has said, is this particular act. So you can even be pro-euthanasia, but realise that this act is so deficient and dangerous from a legal point of view and a practical point of view. And one other point, in the Act it says at the moment that you have to be 18 years of or older to be considered for this, which is also very distressing that even an 18-year-old would consider it or be eligible. But the Attorney General, the previous Attorney General, said that limitation of 18 is actually not consistent with the BORA Act, the Bill of Rights Act, which means it will be contested and reduced so that the eligibility level will be 16. That's likely to be an outcome, highly likely. So then you have to. But again, that's not what you're voting on. But
it's a consequence.
Considering the consequences of this legislation, and we're not just voting. You could say, well, somebody like Michael Collin, the former Deputy Prime Minister, who's spoken out in favour. He's in favour, and if you could legislate for one person or a group of white middle-class people who are well educated, who can get all the palliative care they need, who can get all the health care that they need, and that they want this, but actually you're legislating for every single person in New Zealand that this would impact upon. So you have to think 360 degrees around this. So when we're voting, you have to think, is this safe beyond reasonable doubt? And I have to say, I think what Ben is also saying, that it's not safe as a piece of legislation.
Right. I just wanted to, I think, we are towards the end now. We're almost an hour now. I just wanted to, maybe I'll start with Dr. Ben Gray about mental illness in to those who've been diagnosed with either cancer or anything. As a GP, if you were to ask about this, and then how do you? It's a little bit difficult, the feeling of wanting to end, because we know as a GP, you need to treat someone with depression. You have to ask a question as a doctor. Would you? Are you at risk of harming yourself? And we have to look after so someone who's maybe their mood got affected because of their diagnosis whatsoever. How are you going to differentiate between the two?
I mean, I think one of the fundamental problems with all legislation talking about aid in dying is that they all mention something about suffering. And suffering is completely undefinable. It's an experience of the person that's talking to you. You can't measure it. You can't determine what's going to fix it. You can't, and in legal terms, you couldn't contest, well, I disagree, this person isn't suffering, because it's all that needs to happen is for someone to say that they're suffering. So that's a fundamental problem whenever we, if you like, go down this track. And the question of the assessment of their mental state is, I mean, it's seriously problematic because on the one hand, for the rest of our time, we're presuming that someone who's saying that they wish to end their life, that there's a problem that we need to address.
Yes.
And that's, part of why we find out whether that's what they're thinking. And I think it's an open question as to whether someone saying that they wish to end their life, how do we decide whether it's something which would change if we were able to improve their care? And I would put that much more broadly than just sort of naming depression. you know,
is it a cry for help? Maybe cry for help. They just want someone to talk to them, or something like that.
And I guess that's the thing, is that it's very hard these don't fit into nice little boxes in either direction. So I mean, I think the idea that someone who wishes to die is by definition depressed is as problematic as the idea that someone who wishes to die is not depressed. You know, that it's sort of it's not something that you can prove or be certain of either way. So I think the whole question about mental illness in relation to this is inevitably difficult, because the process of dying is hard work for anyone. As you get older, as you get closer to the end of your life, there's a whole load of tasks that you need to do. There are a whole load of matters you have to address, and it's often hard. And so I think that whole area is deeply problematic. And I'm sure you agree, Sinead.
Yes, yeah. I mean, the symptoms and signs of depression are very often within the context of, say, for example, someone who has advanced cancer, you know, fatigue, inability, you know, so it's very difficult to diagnose or to separate depression from someone who has an advanced illness for which they may have the same symptoms. Does that make sense?
Yeah.
And then the other issue in this act, it doesn't require that everybody is referred to a psychiatrist to get a second opinion about their mental state. So yeah, I agree with Ben.
Okay.
Well, and in fact, one of the things as a GP that I find challenging is when someone comes to see me and they are very unhappy as a result of a family member having died. Are they grieving normally, or are they depressed? And there isn't an answer. And arguably, someone who is in the last stages of their life, being unhappy and short of energy, and all of those features of what we might call a depression, you could argue may well be just part of the process of dying, and to call it depression and therefore something we need to treat, as opposed to just enabling them to work through the process. I think is, you know,
just giving them the care and love to just go through it, process it. Yeah.
Okay, I'll take that. That's good. Yeah, Dr. Donnelly, would you like to go through a few more points, or anything else you wanted to say to our viewers and to those who are going to vote on the 17th of October?
Well, the most important thing is to be able to, that the title of what's going to be on the paper, the ballot paper is, and somebody can correct me if I have it wrong, but do you agree with the End of Life Choice Act coming into force? So when you see that on a piece of paper, you'll say End of Life Choice. Oh, that sounds like a good idea. I mean, that you might even think that's palliative care, because palliative care is all about giving you choice. You know, how can we look after you? What do you need? Who do you need? So it's very confusing. It's kind of a euphemistic term, well chosen by those who are in favor of this act. So be very careful about it may look like a nice term, but in fact, underneath it is euthanasia. This is what they're talking about, introducing euthanasia-assisted suicide in New Zealand. And once again, you can be in favor of the idea of euthanasia-assisted suicide, but this particular act is extremely dangerous. It's poorly written, and it's going to, in my view, put an awful lot of vulnerable people at risk.
Yeah, and I think what I would add to that is that, you know, we're going to be voting. And I think that anyone who's voting, and I really applaud you for running this session, but you need to know what you're voting about. And if all you do is read the title of the referendum, then you're not making the most of the privilege you have of being able to vote. And so I'm sure that you will, as a part of this, make links available to people for more information if they're needing about the detail of what this is about. And I really think it's a very good idea for everyone to understand precisely what it is that the referendum is about, and to be making a clear choice as to what they're doing, rather than sort of, as Sinead's suggesting, you know, oh, that sounds all right, without really understanding what the detail is.
Yeah, I think it's easy with that title to be misled. You know, whether it's been specifically written that way for that.
It's what it is.
Yeah, it is what it is. So, but what about from our perspective, being Muslim, we have certain understandings and things like that. What about the other religious groups? Are they speaking out to try and encourage their, remind their parishioners and things like that what their beliefs have on this have as part of their belief system?
I mean, I think part of this will be the same for other belief systems as your own, that there's a wide range of it's a broad church, as the phrase is used.
Yes.
And certainly within the congregation that I'm a part of, there's a significant number who would be in favour of the referendum passing. Right. So, I think within the communities as a whole, there'll be a wide range, but certainly in terms of the sort of the literal formal teachings of many of the great faiths would be that euthanasia is wrong. But I think the important thing to say is that, as Sinead has pointed out, this is about a particular act describing a particular set of things, and it's about individuals voting on it. And so you as an individual need to work out what it is you think, and you may well be guided by your faith, and I think it's useful for the faith communities to talk about in what way this act intersects with their faith. And there's a whole lot of talk to be done in that respect.
Yes.
The a group of religious leaders, including the Muslim community leaders, I think, Jewish, Christian, they had an advertisement, I think, in a newspaper a few weeks ago, and they produced a letter, and had a media statement outlining their opposition to this act. And then the Pacific leaders as well, there's a group of Pacific leaders who I think are coming from a Christian background. They have also are working in their community, expressing their concerns.
Yeah.
Okay.
Yeah.
Look, I think we're coming towards the end. Mama Thompson, would you have any question to any of our guests?
Unfortunately, I missed the first part of it, but I've really enjoyed the discussions and things going on. And, I applaud you guys for coming on, and thank you for bringing this out to the attention and bringing out what the flaws are and things like that. And like you said, it's a choice for everyone, but it's knowing what they're choosing is the most important part. It's like a little bit shady in a grey area, some of the way things are written, from what I understand, and the way it's being put across. And like even the title sort of a little bit seems a bit misleading as well. So I think people educate themselves, those listening educate themselves, tell their friends and family to educate themselves and have discuss it and just look at it for what it is, not just look at the title and think, let's just tick the box on election day, like maybe they do for the party they're voting for. Just be even more vigilant on this than that, I would think.
Okay. Dr. Ben Gray, do you have a few...
Just probably looking again at the chat, there's a comment made by Kathleen about forgetting about the family. And one of the things that strikes me about this is that it is a very individual-focused piece of
right. Yes.
You're able to apply for this without your family knowing about it. And it's one of the reasons why I dislike it, is because it's so individualistically focused, and it seems to me that we need to be doing more to strengthen our families and our communities as collectives, and less of this sort of narrowing down into individuals. So I think that's another feature of this act, which I think is unpalatable.
Yeah.
We're becoming a heartless society, I think.
Yeah.
But like you said before, we always think about that person, but we as a general practitioner, we tend to actually see more the family.
Yeah.
Something that happened to one person actually affect the whole family.
Yeah.
The whole family members get affected, and how do you mitigate it? How do you actually support them? And it's like Dr. Donnelly said, the act is just too, I think it's been rushed somehow. That's how I see it when I read about it. So, but yeah, I think we're coming to an end. So a few last words from you, Dr. Donnelly.
Well, websites that I think are good it's called Risky Law, and there's also called Vote Safe. And the Vote Safe website has a quiz, a 10-question quiz, and just says, what do you know about the bill, or the act? And that's very useful because it draws out that people think that this act is about, person coming off a ventilator, or stopping antibiotics if someone is dying. So by doing this little quiz, you realise that the act is not about that, that those things are already legal. So Vote Safe is a good website, and Risky Law is a good one. And I like the one that, which the doctors say no, but it's just a letter signed by 1,700 doctors just saying why they wouldn't want to be part of ending someone's life.
You mean the votesafe.nz? I'm just going to put the link up here, so any of our viewers later can actually look it up. Just try it. Is it the votesafe.nz? Is that one there? Yep. Okay. All right. Yeah, and I think we're coming to an end, unless anyone else has wanted to say a few more words or anything else. Muhammad Thompson, maybe you can conclude our meeting today. I've done an introduction, so it's
yes, it's good. So, well, thank you guys for coming along. Much appreciated. You're very busy people, and I'm sure this, with things going on with COVID and all these other things, we're all busy with those sort of things. But we much appreciate you come on, share your views, hopefully educated people a bit more about this referendum, and hopefully people will go to these websites, check it out, and then be educated and be able to vote properly for the community and their families. Thank you again for coming on. Much appreciated.
The last thing I would say is please vote.
Yes, of course.
Right.
It's our right.
Yes.
Many people have died to give us that right, so we should exercise that.
Yeah.
And make it count.
Yeah, make it count.
Yeah.
And thank you for organising this. Thank you.
No, appreciate it. Thanks for coming.
We'll invite you more for more things in the future. Hopefully.
Yeah, very much so. Good.
Thank you.
Thank you so much.
Let me hear you.
Okay.